Welcome to the Homegrown Heart Podcast, every Friday at 7 a.m. Mountain Standard Time with your host, Dr. Amanda Ryan, D.O., MBA, interventional cardiologist, and an expert in her field. This week's topic, what is PAD, P-A-D, and the importance of screening leg, vein, and artery issues. Please help me welcome our host, Dr. Amanda Ryan.
Good morning, Carlsbad. It is the Homegrown Heart. This is Dr. Amanda Ryan, your friendly Carlsbad, New Mexico interventional cardiologist. So last week's episode, we were able to talk with several members of my team about some of the complexities of running a rural cardiovascular practice. I think that was probably eye-opening, and thank you for some of the feedback, by the way, on my session on board exams and to be or not to be board certified. What does that really mean for your physician? It was kind of funny. I had someone tell me the other day, like, somebody when you first came to town was telling all kinds of people you weren't board certified, and I was like, really? Why? That's so strange to me. And they said, well, you don't advertise it. I was like, I don't think you needed to advertise it except to the insurance company. In the era I grew up in, just so everyone knows, most of us are board certified. So, to advertise it is kind of, triple boarded. So if you need to advertise what I am, it's triple board certified for your own knowledge. In the major areas, and then 2 or 3 minor areas too. Like I said, I've seen people 6 and 8 board certified. And then I've also seen some really good doctors that were not board certified. And that had to do with, again, one of them trained in England, got excellent training, came to the United States and was able to go back through some things. But there are exact rules, and sometimes it's just a little bit of a political nightmare to get through all the different bureaucratic agencies involved in licensing and accrediting physicians. So I just want you to realize that it is good to ask your physician if that's something that you've researched and really feel like is important. Don't assume, I don't know, again, I have enough initials and I haven't ever really been the one to just add on more and more and more initials because that would just be harder to sign my name. It's pretty much illegible as is. So I just stick to 2 sets of initials. So, and I don't know, board certified, you might see someone write B, C, B, E. Yes, again, in the board certified, board eligible range, but I think you go back and watch my podcast on that for a little more insight. So ask your doctor. You'll kind of get some good information, I think. So September is Peripheral Arterial Disease Awareness Month. And at Advanced Heart and Vascular Center of New Mexico, Advanced ASC, and Partners in Heart Health, we are so excited to announce that we have several community screenings. We actually have a screening in Carlsbad, Artesia, Hobbs, and Roswell. Those will much be on the successive Wednesdays in the month. September 4th, which is next Wednesday, is going to be at our ASC, a PAD screening. And the following Wednesday, I think we'll be in Artesia, then we'll be in Hobbs, then we'll be in Roswell. So please look out in our different communities for these different sessions. The point of them is to really get people who have leg symptoms who have not sought care with their physicians before. And in my MBA, one of the physicians who had been the leader of a very large New York Presby system, from a medical officer standpoint, he was a graduate of my program and was very big into the population health side of things currently. And he was like, oh yeah, we kind of joke that whenever a health fair comes to town, the carnival's coming to town, and all the people show up and you give out their free things, and that's pretty much the people that attend those would probably be receiving care anyway. So really figuring out how are we going to reach some of the people that are not receiving the kind of care that they need. This year, we're really going with our senior centers. We're really trying to let everyone in the community, we're partnering with so many different advocacy groups in each of our communities, and so that we can really get the people that need help with things like leg blockages. Again, what kind of symptoms might you have? Let's just start there. Leg heaviness, poor pulses, sores that don't heal, this purplish brown discoloration of your legs, pain in the back of your calves when you walk. That's called claudication. That's a great indication that you might have blockages in the arteries in your legs. But again, as a classic symptom for PAD, no different than women that have coronary artery disease, only about 1/3 of women actually get chest pain. The same with claudication. Only about 1/3 of people get classic symptoms. Turns out we didn't all read the textbooks and we don't all show up with the quote unquote classic symptoms. So in our practice, we actually treat veins and arteries, particularly in the legs. And we don't always expect the patient to be able to figure out, you guys out there, whether your problems are more your arteries or your veins. So if you come, we have questionnaires that help us kind of limit, if this could be arterial or venous as far as a problem goes. Then we'll proceed to further testing based on what symptoms that you might have and your physical exam, as well as the questions you answered on your questionnaire. So if you come to one of our screenings, actually we'll use a little handheld thing called a Doppler. It checks your pulses. Sometimes you can feel your pulses very well just with your fingertips, but other times we can't feel them that well and we'll actually have to use a Doppler. So if you don't have a Dopplerable, quote unquote, pulse, that's when things have potentially gotten really bad from a peripheral arterial disease standpoint. What does peripheral arterial disease mean? In a generic sense, it means blockages in arteries anywhere outside the heart, which is more referred to as coronary artery disease, atherosclerosis. PAD and CAD, you could say, are under the subtype of atherosclerosis, which is a fancy word for saying that you have developed plaque, athero is plaque, within your arteries at different places in your body. When we say PAD, classically, what we're referring to in the medical world is blockages in our legs, but the truth is blockages in our carotid arteries in our neck, abdominal aortic aneurysms, blockages in our kidney arteries, all of those things are actually peripheral arterial disease as well. So next, how do you get peripheral arterial disease? So one of the number one ways, there are two groups of people that are very high risk for peripheral arterial disease. Diabetic smokers. Those are going to be overwhelmingly the highest risk. And this is going to be a side note, Dr. Ryan slipped to another topic, but I don't know if people were aware that diabetes is first of all, it's epidemic out here and it's epidemic in America in general, type 2 diabetes. And I've talked about that several times during our podcast. Hold on just a minute. One amazing realization I had, and not amazing in a good way, amazing in the so many people, when I first came out here, I think I've said this before, the first 10 patients I had that had acute heart attacks were 35 to 45. And I think 8 out of 10 of them were diabetic, type 2. And were having heart attacks at such a young age. Really made me realize what a significant issue diabetes really is. Well, diabetes now is such a significant risk factor for heart failure that we're considering you stage A heart failure just if you have diabetes. You don't even need a diagnosis of heart failure. You've never been short of breath. You've never had a symptom, but you are at such high risk of developing heart failure if you're diabetic that we're just going to go ahead and call you stage A heart failure. Next, things like coronary artery disease, peripheral arterial disease are rampant in patients that have diabetes. And you might ask yourself, how does that work exactly? And again, we have Dr. Ferraro. He's an excellent endocrinologist, diabetic specialist out of Artesia. And I'm going to let him deal with the nitty gritty of diabetes as far as on a pathophysiology standpoint. What I'm going to say is when you have excess sugar that circulates, it collects in your arteries, plaque builds up, gets with cholesterol, and basically blocks up your arteries. That's going to be a simplistic explanation of what's going on. And again, at different times, sometimes when you're doing a podcast, you have to ask yourself, who is your audience? And my audience is other physicians, young women, but primarily it's the patients. I am here to educate you. So most of the time I try to make it where lay people can really understand what we're discussing. So sometimes things might be a little higher than what people can understand, might be a little bit lower than what some people's understanding levels are, but I'm trying to teach to the masses as much as humanly possible while we spread our knowledge. And what factors might really, so diabetes and smoking, we kind of said, are two of the big risk factors for PAD. What's really going on with peripheral arterial disease? Again, this is going to get pretty technical here. This is impaired endothelial function, heightened inflammation, propensity towards thrombosis, and an impaired functional capacity with reduced physical activity. My PAD patients, getting them on an aggressive walking program is so important to their overall success. And a walking program for somebody with significant blockage in their legs literally might mean walking 2 or 3 minutes a day. How do you treat peripheral arterial disease? First, we're going to go back to how do we find out we had peripheral arterial disease. Then if we do, exactly what do we need to do to treat it? Smoking cessation. And again, we talked to Bob Kolker. That was a really great podcast where we interviewed Bob with a lot of his different issues. He has peripheral arterial disease. He told us a lot of what he had. I don't know if you remember. He said he had aortobifemoral bypasses, or I think he said he had some bypasses of his legs, but I'll tell you that he had aortobifemoral bypasses. That means that his legs were so clogged up with blockages that he had to be open from top to bottom and bypass grafts literally put from his aorta to down around his leg blockages. So smoking cessation has been a major goal. You also heard Bob say that he was smoking over 3 packs a day at the height of his smoking. He's down to a half a pack. He's been there for a while. We're really hoping this year to get him from half a pack to 0. Because smoking cessation is really the goal, to stop these leg blockages from coming back. And again, when I educate my smoking population, I repeatedly say, again, every smoker does not get lung cancer. I don't know if it's fortunate or unfortunate as far as there's always somebody whose grandpa lived to be 100 despite smoking 2 packs of unfiltered a day. And he probably worked a lot physically harder and didn't have the same diet that we have either currently, to be honest. But we all know somebody that drank heavily their entire life and never had problems with their liver, never developed heart failure from it. We also know many people that do. So sometimes certain things, maybe you have a genetic predisposition and your smoking is lighting a match to that genetic predisposition. So everyone is different. But what I can consistently tell my patients is that if you do not stop smoking, whatever problem you've tended to have, if it's blockages in your heart arteries, if it's lung breathing issues, if it's blockages in your leg arteries, if it's aneurysms that are developing, you will keep getting the same problems over and over again if you do not stop smoking. And that's just, again, we partner together. New Mexico Quit has a really great program that can help people, give free resources, free nicotine patches. So we really encourage people to utilize that. There are support groups. Hypnosis has worked for some people. But at the end of the day, the number one, people ask me all the time what really works. There are some medications that I tell people will, quote unquote, help take the edge off. Wellbutrin is good for that. Chantix is an option, but it causes some people crazy dreams or mood swings. So then you don't know if it's the smoking cessation or the medicines that's causing you to feel how you do. But the physical addiction to nicotine lasts about 3 days, and the mental addiction lasts a lifetime for most people. So it really is an internal, you got to be ready to stop. And when you are, we are there to partner with you so that you can achieve those goals. Lipid management. You've got to control your cholesterol. LDL is the quote-unquote bad cholesterol, and HDL is the good cholesterol. Again, simplistic version of the situation. But when I see people, we keep driving that target LDL for people particularly that have PAD lower and lower. Actually, the PowerPoint I'm looking at is a little bit old. It said target LDL less than 100. Ooh, we're at a target LDL of about less than 55 in some people with significant PAD and CAD. Not only the traditional statin drugs, which is a whole lecture in and of itself, we have some there's some newer injectable drugs on the market. At first, we thought medications like Praluent and Repatha, those were just for people that quote unquote were statin intolerant. Now we've realized we might even use those in conjunction with someone on max statins who's still struggling with cholesterol and the end effects of cholesterol. And that's also a question I get in my office a lot too. I had a lady last week, it was a very interesting visit. Obviously a genetic profile towards this whole metabolic syndrome, belly fat, pre-diabetic, very high cholesterol, LDL, low good cholesterol, high triglycerides, and a very high, what we call a highly sensitive CRP, which is a marker of inflammation. So I was looking at this early 40s patient and, talking to her, and I was so excited to have her in my office. Because as an interventional cardiologist in our rural area, I'm most often faced with treating end-stage disease. And that's because that's what comes. The emergency heart attacks, the legs that have no blood flow, the kidney arteries that are getting no blood flow. That's what I deal with most days because that's what I have out here. But prevention is my real passion. And having a young woman in my office that has not had one cardiac-related issue yet. However, I can look at her, she's very educated about it, has a strong family history. Her and I just sitting there talking, and it was a long visit. I spent a good 45 minutes with her. And again, I often don't have 45 minutes depending, but sometimes I try to meet people where their need is on that day. If you're doing well and it was just a routine follow-up and your EKG is looking good, your visit might be 5 minutes. And if you need 45 minutes of my time, I do my best to give that to you as well as my nurse practitioners. So on that day, her and I really sat down and talked about all of these different markers of inflammation, of cholesterol, what the numbers meant, what could we be doing, of her true risk of developing significant coronary artery disease, peripheral arterial disease, strokes in the next 5 years, next 10 years, and then what we're really going to do to decrease those risks. So that was great, and I'm looking forward to really working with her in partnership. Blood pressure control. You really want a blood pressure in people that have significant PAD, less than 135/85 as best we can. Controlling our blood sugar, again, we want a hemoglobin A1C, less than 7, closer to 6 we can get, the better. Again, if you are diabetic and I ask you, even if another doctor is quote unquote managing your diabetes, because again, we've kind of got our hands full in our cardiovascular practice, and I've shied away from aggressive diabetic management, leaving that to several good primaries as well as endocrinologists in the area. But we do bring it up. We do discuss your diabetes. We discuss the different medications that you're on. And a lot of patients, I ask them, what is your hemoglobin A1C? And they're like, I don't know. And what is a hemoglobin A1C? If you are diabetic in 2024 in America, you should know your hemoglobin A1C. That kind of measures your average blood sugar over the past 3 months. I think I've told this story on a previous podcast, I don't know, but as part of my medical school, we had to do 2 months of a rural rotation as fourth-year medical students. My friend and I, my roommate from medical school, Leslie Akram, who's an amazing OBGYN in the St. Paul, Minneapolis area currently, decided to link back up the end of our 4th year and go out to rural Hoisington, Kansas, and do 2 months of a rural rotation out there together. While also I was training for a mini triathlon, and she was training for a half marathon. So, and what an experience it really was. The staff at the small hospital in Kansas, as well as the physicians, were used to having medical students. And they just welcomed us as part of the team. The patients of the community were happy to have us. It was just such a great experience overall. But one patient really stands out in my mind to this day. He was talking to the doctor. His blood sugar was like 150 most of the time on the labs that were drawn over like 5 years. And we had looked back on his sets of labs, and A1Cs were first coming out at that time. And he checked his A1C, and it was literally like 17. I don't think I've ever seen an A1C to this day that was that high. And I'm not sure, the assays have changed along the way, I'm sure. I don't really know. But let's just say that meant his blood sugar was probably averaging like 600. And the physician and I were like, this can't be right. There has to be a problem. This isn't accurate. What is going on? We don't trust this new test. We talked to the patient then at his visit, like, sir, this is what we found and it doesn't make sense. Like, he literally was like, yeah. Basically, I don't eat. I fast for 2 days before I check the labs for like the last 5 years. And outside of that, I eat nothing but McDonald's and I drink Coke all day, every day. Like 12 Cokes a day. And I remember the physician being like, so you're treating me? Like, you're not really treating yourself, you're treating me because you wanted me to think that your sugar was okay. Which at the end of the day, what is that to me? Like an attaboy, like I'm patting myself on the back that you have good blood sugar control. I mean, realistically, this is about you. This is not about me. And that just, to this day, I was like, wow, eye-opener. But again, hemoglobin A1C does really allow us to kind of get a feel for blood sugars over the past 3 months, not just one reading. So we're going to talk about a patient case for PAD. So patient case is a 58-year-old gentleman. He presents with exertional left calf pain that happens at about half a block. The symptoms occur reproducibly with exertion and are relieved by rest. The patient is diabetic, has high blood pressure, tobacco use, and known peripheral arterial disease. He has had a left femoral popliteal bypass. Now again, when you hear these terms in healthcare, like we all have our jargon, but even for cardiology staff in my office, someone's like, wait, aorta bifem. And I said, you just need to think, where does it start and where does it end? So if you have a femoral to popliteal bypass, your femoral is up in your thigh area. Your popliteal is what we call that artery behind the knee. So you've had a bypass probably because that artery in the thigh called your superficial femoral artery had a complete blockage. The patient's medications include lisinopril, metoprolol, atorvastatin, aspirin, and metformin. So a lot of you might recognize some of those drugs for diabetes, for blood pressure, for cholesterol, and aspirin again is an antiplatelet drug, helps keep the platelets from sticking to stuff. On physical exam, the patient had palpable femoral pulses and diminished popliteal and distal pulses. Not a lot of color changes or skin breakdown. How are we going to establish a diagnosis of peripheral arterial disease or assess and help localize it? So this is a very good picture that I'm going to show you guys as far as peripheral arterial disease and where the claudication symptoms are and where the blockages might be. Could be up in your pelvis area, that's going to be your aorta itself or your iliac artery. Could be in your thigh, again, that's going to be more your femoral artery or your calf. Or then it could be your popliteal or what we call BTK or below the knee vessels. In an ideal world, we have 3 vessels that reach our foot with good blood flow. And in many of our patient population, I'm trying to save that one vessel that actually still reaches your toe. Because a lot of our patients are lucky if they have one vessel. And I'm sure some of you know what happens when we lose that 1 or 1.5 vessels that go to our foot. That's when the amputations start. It's really what end-stage peripheral arterial disease is about. Limb ischemia. That means we're not having enough blood flow to save our leg, and we may end up with amputations. Again, classic claudication, a cramping, tightness, aching, fatigue can be in our buttocks, our hip, our thigh, our calf, or our foot. It is worse with exercise. It's consistent with the distance. Like I can go X steps before, but you know what I see so much in my diabetic or elderly population? What happens if they really have significant PAD? They just stop walking. They don't have angina either. They don't complain of chest pain anymore. It's like my VA patients where I trained in St. Louis. Yeah, I don't have chest pain unless I walk, so I really don't walk. I just go from my truck, again, truck drivers, #1 PAD, CAD career in America. They just go from their truck, they park as close as they can, they go into their convenience stores as they travel America. They don't get too much chest pain and too much leg cramps because they just don't walk very far. So first step in diagnosing peripheral arterial disease is an ABI, or an ankle brachial index. What does that mean? We're going to put blood pressure cuffs on your arms and we're going to put blood pressure cuffs on your legs. And the pressure in the systolic blood pressure in your arm and your leg should be about the same. If you have a lot less blood pressure in your legs than your arm, you probably have a blockage somewhere between the two. So that is kind of a basic screening test. Then next we could do an ultrasound with Doppler. Then that might help us better identify exactly where this blockage is located. Sometimes we could go to a functional test and put you on a treadmill and see how a little bit of exercise brings out your symptoms as well as changes your quote-unquote ABIs. Then we move on to advanced imaging technology, which can be a CTA, an MRI, MRA, or even a peripheral angiogram. A peripheral angiogram, in this day and age in our office, we're going to go through your wrist, we're going to put a little sheath in there, and I'll show some videos of that in future sessions. Basically, we're going to come all the way around and we're going to actually shoot dye in your lower aorta, in your abdomen, as well as down both of your legs to really see where you have a blockage. And if one is enough, that we need to do something about it. By the way, what do we do about it? The way I explain it to most people is that it's like a roto-rooter. We're going to roto-rooter out the blockage in your legs so that you can have enough flow that these symptoms improved, or that your wound heals, or that you don't start getting amputations. So there are a lot of different devices for this quote-unquote atherectomy. And this is endovascular options. Sometimes, like in Bob's case, the blockages are so bad, or we've tried those options and we end up with open vascular bypasses of our legs. The problem is you have to have a healthy, like I said, if you only have one vessel that goes out to your foot and there's a lot of calcium and blockages in that vessel, I really can't put a bypass to that vessel because that vessel is not healthy either. So we've really realized that we work in conjunction. I work with Dr. Paoni a lot from a vascular open standpoint, and he's at UMC in El Paso. I also work with Dr. Raja, who again is a true critical limb ischemia expert in El Paso. Probably one of the top 5 in the country for preventing amputations. And he has taught me so much. He's taught so many physicians in the area and nation, really worldwide, how to really approach significant peripheral arterial disease. And as he works towards retirement at someday, I don't know, I hope he has a good 5 to 7 years of work still, but he's really trying to make sure that a lot of us are ready to carry on his expertise when it is time for him to focus more on his family. He just became a grandpa not that long ago, and he's definitely enjoying that route. So we really respect and appreciate all the help he's given us at advancing our peripheral arterial disease treatment program. So again, in this angiogram, and I'm going to show a couple angiograms that we actually have a patient that we did at Advanced Ambulatory Surgery Center of Carlsbad, New Mexico. Just amazing technology. And can I just say, we have the latest, greatest technology in our surgical center, which is wonderful. Our ability to visualize is so high. We have what's called IVUS, intravascular ultrasound, where we can really look inside your arteries and see the size, the kind of plaque you have. I don't know if everyone's aware, all plaque isn't created equal. There's soft plaque, there's hard plaque, there's all fibrotic plaque, there's all kinds of different plaque. And intravascular ultrasound and some of these different technologies really help us be able to know which treatment option is best for you. So we revascularized the patient number 2 that we had talked about. That means we went in and we roto-rootered and we used a fancy balloon called a drug-coated balloon that helps put this chemotherapy agent actually out into the vessel, just trying everything we can to keep that open. In the peripheral arterial disease world, by the way, coronary stenting has came a long way, and those stents might stay open 15 years at this point. And often so will our bypasses, 20 years. Again, this LIMA bypass graft that comes from people's chest that we often put on the LAD during open heart surgery, they're probably 45 years in some people right now, still open. But bypass in the legs are not like that. And peripheral arterial work in our lab does not, we're trying to keep things open for maybe 1 year, maybe long enough just to heal that wound. I mean, this is, unfortunately, I'm very upfront with people. This is not physicians just trying to, make a dollar. It is just bringing you back over and over to work on your legs. Trust me, I want to open your leg blockage. I want you to stop smoking, to control your sugars, to get on a regular walking program, and for me just to see you in my office for a routine 6-month follow-up. I do not want the same person on our heart cath table over and over again with the same blockages. That's not what Dr. Paoni, Dr. Roger, any of us with a passion for helping PAD patients, that's not what we're looking for. But the reality is this is your chance, if you're one of those patients, to really partner in your own health. You have got to do the things you need to do. Now, sometimes people do everything they need to do and they still keep having problems, and that's very frustrating. I have a patient that has significant peripheral arterial disease that will be working on his blockages in the next few weeks. He had open heart surgery about 5 years ago. He drank heavily, smoked heavily, had diabetes. He has lost 30 pounds, is on no medications for his diabetes anymore, does not smoke, and rides a bike a good 10 miles a day. But sometimes that atherosclerotic process was already advanced enough to the point where you still get these significant blockages. He probably didn't really get symptoms until now because he was doing everything he really needed to do. But despite his long bike rides, his leg cramps have just gotten worse and worse to the point where he really felt like we needed to address it. So we will be working with him, really trying to help improve that blood flow. Then we'll reassess it again with new ABIs and new arterial ultrasounds and kind of see, hey, did this get better? So again, PAD is very common. It has significant impact upon cardiovascular outcomes. The treatment of PAD, even if it's asymptomatic, really needs to focus on risk factor modification and keeping blood flow to avoid amputations. So we're really excited to partner with the communities around us for PAD Awareness Month in September. I appreciate everyone's attention this morning. If you're in our area, come out, look on our website, follow us so that you can on TikTok and Instagram and Facebook so you can really tell what we've got going on. Again, we have our casino night on September 14th here at the Valley venue in Carlsbad. Great opportunity to support our foundation and have a lot of fun. We have casino dealers coming from Albuquerque. Our prize packages are just wow. We have, again, a signed Young Gun script by Charlie Sheen. We have David Yerman bracelets. We just have so many great. We have Blanton's whiskey. We have all kinds of neat prize packages. So join us for that as well. All available on our websites, or give our office a call, and have a great week. Thank you.